How are you all?
Good, good.
Great. I've got the coveted last spot of the day, which means I'm fully aware of the fact that I am in your way of happy hour or whatever other fun things you have planned for the rest of the day. So I will do my best to be hopefully a little entertaining and informative, but perhaps I'll even wrap up a little bit early, in which case I'll expect some extra applause. So, they always say when you have an opportunity to present, whether it's an esteemed group like you or the kids I coach for youth athletics, you can hope to maybe get 3 or 4 things to stick. So, in the purposes of full disclosure, I'll give you those 3 or 4 things up front. If you don't like it, then you can get to your thing faster, I guess. So, if you subscribe to the notion that in order to influence behavior, in order to improve outcomes, particularly with your most difficult patients, that you have to find a way to connect with those individuals in a really meaningful and personal way so you can understand what they're doing, so you can change those outcomes, then knowledge is the currency of the realm. And that knowledge is perishable. It begins to deteriorate the moment you capture it. One of the challenges that I think organizations have today with decision support systems is that we're doing a much better job starting to look at the data in the aggregate, right? Understanding all these things that are happening and starting to turn big data into small data, but that big data is large part past data. It's not what's happening at the time of the transaction, it's what's happened in the past. And for our high-risk patients, a lot of times that means we've got to try to find them again to share that information with them or to act on that information, which is a challenge. Good people are critical and important for building your organization. There's no question about that. But without a system, and given the complexities of the job that all the folks in this room have, without a system to catalyze those individuals, to facilitate the things we're asking them to do, to put data into an actionable form, and ultimately to make the right thing easy to do, is a real challenge. It's imperative that you have something that makes that happen. And then lastly, sort of the easy one for me because I'm not that smart, simplicity and all these things I think is our friend, right? Baby steps and then go to a full sprint over time. So I won't ask for a lot of audience participation today, but I'll ask for a little bit. How many people recognize what this is? Come on. You got to look smart in front of your friends. Put your hand up if you know. If you don't, it's okay. All right, good. So this is a Google self-driving car, which is kind of neat. It's a little Euro-looking. It reminds me of the thing I used to push my toddlers around in. It was red and yellow, right? So I don't know if it has the machismo for some people, but it is what it is. It's a starting thing. This is an interesting project. The Google X project, as it's called today, started in 2009. It was founded by Sebastian Thrun, who's am I okay? Do I sound echoey to you guys? Or I'm good? I used to walk around a lot. It's tough to stand still and my legs are moving. So it's founded by led initially by Sebastian Thrun. And Sebastian Thrun's a pretty smart guy. He is not only the former director of Stanford's AI lab, but he also was the winner of the DARPA award in 2005, Grand Challenge Award for building an autonomous vehicle. Super smart guy, really strong history. Now he's since left, but they've done a pretty good job of getting some really good people to back him up. According to an article last week I read in Gizmodo, there's 200 people now working in that organization, and that's the top people from academia, robotics, artificial intelligence, coming together to build this apparatus. It's not cheap. Each one has about $150,000 worth of equipment inside of it, including a $70,000 LiDAR, which is used to figure out what's around you so it doesn't run into something. Fun fact, last week, one ran into a bus. So, things don't work out sometimes. So here's the thing. Ultimately, I think this is a successful endeavor. It is something that's coming, just like change in healthcare is coming. And we expect an organization like Google to be successful. They have all the resources. They have all the right people. They're doing the right thing. But it's not always that way. How many people, by show of hands, recognize this guy? Not very many, right? Nobody. Sorry. All right. Behind him, I'll get to him in just a second. Behind him is an Acura, I think it's an LXI, which is a model that you might see at the grocery store or at the shopping mall when you park in the garage. It's a regular car. It's meant to be driven by regular people just like you and me. There's nothing about it that's supposed to be self-driving. This project is led by George Hotz, who, although a really smart young man, has no background in AI, has no background in robotics, has no background in automotive design. His claim to fame is he cracked the iPhone as a teenager, and then the Sony PS3, and there was a big litigation back and forth. And he is a little high on himself, but he's smart. Work on this project isn't 7 years old. It's not even 7 months old. He started working on this project at the end of 2015. Just him. He's doing all of this in his garage, right? Where he sleeps and eats. It doesn't look like a pretty place for me. It reminds me of college. It's got $20,000 worth of equipment in it today, and that's going to come down because he actually has a LiDAR in it as well as a laser radar system. But he's replacing that with consumer-grade cameras that are $13 a piece, 6 of them on the car, to drive the cost down even more. Interestingly, his prototype is up and driving, and it has been now for more than 2 months in California. If you drive out there, if you live in California, you might see this guy driving around. So here's the thing. This kid has no money, has no background, is clearly smart. How did he catch up to someone like Google that's doing all these amazing things? Tesla, all these groups that have all of the advantages. And I would argue that there's a series of things. The first is he embraced a very simple concept, and then he used technology to facilitate that. His simple concept was, and so we'll contrast this, and by the way, I'm not an expert in self-driving cars, so if I do something a little bit wrong, you have to give me a little leeway. But the basic principle, as I understand it, most of the major automotive manufacturers that are doing this, is they're taking all of the data on driving, and they're trying to program the computer to drive. That's driving, I'm going to type it in, that's how you drive. Now, he realized he didn't have the resources to do that. He realized he didn't have the time to do that. So what he said is, look, that computer I can make really smart. And there is a computer that already knows how to drive. It's right here. I've trained this computer for years on how to drive. So what he did is he took that same computer, that same artificial intelligence engine, and he had it watch him drive and learn to drive. And in a couple months, he's got a car that's driving itself. And so how does that transition to healthcare? I'm going to tell you a story about an organization that had a simple concept as well. Right? They didn't have a ton of resources. They didn't have a lot of time, but they were able to make some really meaningful change and impactful change with their patient population. That's Reliance Quality Healthcare. Background on these guys, they are a 2014 cohort MSSP ACO based out of Michigan. When I met these guys back in 2014, sorry, it's driving me nuts. They had about just under 15,000 patients. 80 or so providers across 37 groups, and they had vacillated somewhere between $175 and $200 million of Medicare expense. I met these guys, interesting, not in person. I met them on a phone call. I got a call at 4:30 in the afternoon. It was a Tuesday or Wednesday. They had an emergency board meeting that night because they were 3 months into the year, and they were really struggling. And they had to figure out what they needed. How could they get going really fast with the resources that they had? So they had great data, right? So those of you who are familiar with the ACO model, we get lots of data from CMS. They had some demographic data they'd started to compile, which was interesting, right? But they didn't have a way to unlock that. So the other thing, if you guys didn't get the self-driving car, you were going to get a Campbell soup analogy, which I'll spare for you without an opener, right? You didn't get it exactly. I did this once. I went camping without a can opener. It didn't go well for me. So they had great data. They just couldn't get to it. They couldn't use it, right? They couldn't convert it. They had a model for engaging from a care management, care coordination perspective, but the problem was they realized is they could be, unless they got really lucky and nailed it on the first run, their learning feedback loop was unacceptably long, right? I do something, and then I wait for my claims data to pour in over the following months and see if it worked or not. If it didn't, I had to go back and redo it, right? So it would take them too long to get traction in the year, and they had to get traction in 2014 to be successful. But they knew if they could impact hospitalizations, they'd make a difference. It's pretty straightforward, right? So the group, incidentally, wasn't big. The whole tagline, 12 people, $12 million, those 12 people was, almost sounds like the lead into a joke. It was a converted attorney, two physicians, and 9 non-clinically trained care coordinators, people to operate the phone. That had to go make this work. But they had a simple approach that we worked on, and it was this. Joe patient steps foot into or out of a acute facility inside of Michigan, Reliance would know instantly. Reliance would outreach to Joe telephonically, and during that conversation, they'd do a bunch of things. They'd learn a little bit more about the visit. through that conversation. What happened? What precipitated your visit? What happened when you were there? What are you thinking about now? And capture rich data about the patient. And they would schedule a visit with that PCP while they were on the phone for that individual and share with that PCP office what they learned about the patient. Joe would go to his appointment, and when he was done, Reliance would follow back up after the appointment to make sure that he attended, that he was actually there, find out about the experience he had, and make sure that he understood what the physician had asked him to do and what he needed to do next to maintain his care. Sounds good, but obviously a lot of challenges we had at the time. So, Myhin, is anybody from that area familiar with Myhin or Simhi? Anybody from the Midwest at all? No? Okay, so there's two regional health information networks out there, health information exchanges, Myhin and Simhi. So they're connected to a number of acute facilities. So we knew that there was information out there, but there wasn't a model at the time that really conformed to the ACO model very effectively. We had to figure that out, find the right data so we can notify the care coordinators. We also had to take this batch of claims data and make it actionable. Interestingly, on the same call, so this is 10 o'clock at night on a Wednesday night or whatever, we had a week to do that. That's when he needed all of his claims data converted and made into actual reports in a week. And then he needed all of this, well, I'll kind of continue it for a second. We needed all that to happen in a single system that would also support and notify folks that from the time of transaction and enforce compliance, call within 24 hours, confirm that the visit was scheduled, and follow up after that visit. That had to be ready in 3 weeks. And we got a little bit of leeway on trying to connect to the HIEs because there wasn't a model for it quite yet. So back to simplicity, right? There's nothing earth-shattering around the concept of connecting with a patient and making sure they see a physician in 7 days. Camden's been talking about that for a long, long time, and if you follow what their stuff, there's great data, 300% improvement if you get this to happen, that 7-day engagement with your PCP. Let's talk kind of the end in mind here with Reliance. What happened? Well, at the end of the year, they saved $12 million, over $12 million. They were the number 2 ACO for the 2014 cohort, and they were top 5% for all ACOs in the entire country. So let's dig into the detail. What changed? The biggest thing was, there's a series of these things. Having awareness of what's actually happened to that patient in a more timely fashion. I talk about data and the fact that it deteriorates, it does. Data at the time, if I can find the patient, and we'll come back to this in a second, at the moment they walk into that ED, it is much more valuable to me than if I know about that a week later. So they got ER visit awareness. They went from 10% to over 90%. And you might ask, well, why not 100%? Because unfortunately, not all the facilities out there participate in one of the health information networks, so we can't have 100% coverage. We went from under 10% managing the discharges to almost 100% of the time they're actively managing those discharges. On average, in their initial engagement period, the first few months, about 20% of the time those patients would see their physician within 7 days of leaving the ED. As they launched that early spring period, it got into early summer, they were up to 50% just with the basics, 50% of the time. Now, here's the interesting thing where I think technology has a role to play. They've learned so much since that early period of engagement. 20 to 50% is a huge improvement, right? That's pretty fabulous. But what they've done is they've listened, they've watched, they've used, they've created reports, they've captured best practices, they've looked for inefficiencies within their group, they've redesigned their process, they've remodeled that from a technical perspective to ensure compliance with their team, and now they're up over 80% of the time. Their patients are seeing their PCP within 7 days. That's amazing. And there's other neat things. So there's some things that we didn't anticipate. So for instance, now we're starting to get better visibility into what's going on with our physician group. So if we see that a patient has walked into an ER and done the initial registration but hasn't been admitted yet, we'll actually look what facility that patient is at, determine if we might have a physician at that hospital system at the moment, and have them go over and talk to that patient to determine if this is something that truly requires the emergency support, or if not, real time, our care coordinator will go out and schedule a visit for that person with their PCP right then, and we'll arrange transportation, and off they go. And that is a stars alignment scenario. It doesn't always work, but when it does, it's important, right? I see some dubious looks on people's faces, but I promise it happened at least a couple times. All right, so 2014, what do we see? So the beginning part of the year, not managing discharges, no great awareness into what was going on. We started to improve that stuff. $12 million in shared savings. If you want to think about it, right, we really were up and fully running for about 7 months, 7+ months, with this in full gear. And they're evolving. They're doing the right things. I mean, I can't say enough positive things about this organization. I take very little credit for all the amazing things they've done because they really did build it on the principle of get the basic things done first and iterate on that, and they're doing more and more today. They've been very successful. So they've gone from 14,000 in some lives to 30,000 in some lives. They've absorbed other ACOs. They've improved their population. I said they've started to incorporate a bunch of new neat things. So we're still waiting for the initial estimates for 15, but they're feeling really bullish about it, and it's exciting. So let's talk about kind of the detail and what actually is happening behind the scenes. So for those of you that are thinking about this, I mean, today, how many people for organizations that are and this would make sense for your business, are actively out there monitoring ADT messages for your patients? Cool. Good results? Pretty good results? Yeah? Excellent. So this is evolving, thankfully evolving, but at the time there was very limited things. So if you're thinking about this, right, we need to have a way to effectively identify, particularly if you're in a group that's managing disparate patient populations, it's not all associated to a single facility. How do you appropriately flag those patients so you can have that information routed to you? In our case, we came up with a mechanism working with the state of Michigan to do that, and then built an engine that allows us to pull that data, strip the HL7 files, which are a nightmare if you've never seen one, potentially, strip that down and put it over into a system. So this is the kind of view. Now, this is not the pretty, there's a lot of really pretty views that I've seen today from other folks. We have got pretty views as well, but this is, believe it or not, a really standard dash kind of view that is up on a screen for a care coordinator at Reliance. And in real time, as things change, as someone is brought in, this changes and the color indicator will flip because time's important. So if I'm trying to reach that one patient that just walked into the facility before they get fully admitted, I need that to be at the top of my list. Whereas other things, I've got a 24-hour window or a 7-day window to make things happen. I have got a rules engine that sits underneath this and tells us what to happen, tells us what to make happen. Thinking about a rich patient profile is also really critical. So there's the basics around here. So we've got claims data, that's nice. But starting to do things like scan the claims data as it comes in to automatically indicate what health conditions are possibly relevant to this patient, and flagging those from a rules perspective so that the care coordinators or the physicians are actively engaging in a conversation with the patient around what's going on there, because some of that stuff isn't self-reported. We've got to dig. Pulling in demographics information to start to complement what's happening with that patient. ADT data, I think we've talked about this extensively, but starting to build a more real-time view. Now, here's one that I don't know that a lot of organizations are doing today, and I think it's something that's worth spending a few minutes talking about. And that is, I use the term de-skilling. I don't know if anyone else uses this term de-skilling, but it's the reality, right? When I was a kid, I went to my pediatrician. He was a physician, a trained physician, and that's who I saw. When I took my kids to the pediatrician, or do today, for the most part, I see a nurse practitioner. Many of our clients, when they're engaging their patients, they're doing that through a care manager, and that care manager probably doesn't have a formal education. They don't have an advanced degree. They may not have the kind of training that many in this room do. And so one of the challenges is, how do we take the mind of a CMO and structure information so that person can have a conversation with the patient that is going to uncover new information? So that's what Reliance is doing. When I talked about that personal conversation that those folks are having, when they reach out to that individual after discharge, they've got a system in place that is pulling the data into the assessment so that when they're having a conversation with Tom Businger, as an example, it's not going to ask me about my history of ovarian cancer. It's going to know where I live. It's going to know the insurance that I have. So there might be a data validation exercise, but they're quickly getting into things that are relevant for me. And as I answer questions around things, it's reshaping the form of the assessment and taking them down new paths. So if I say, hey, I'm having chest pain, as an example, it might immediately flip over and start asking me about, do I have any shortness of breath or heart palpitations or other things, and lead that individual down the road really quickly to get them moved over to the right place. So in that case, it might be calling 911. In other cases, it might be listing something like, hey, this person has COPD, and they're still living in conditions that aren't conducive for that, and flagging that information so the PCB can address it during their visit. So building that rich patient profile, and then getting back to making the right things to do, making the right thing easy to do. So prioritize cues for coordinators. Building the unified patient picture of the patient, so we really understand everything that's happening. Integrating rules and workflow engines so that people are reminded at the right time what they need to go do. Scheduling a persistent follow-up. So not relying on the individual to remember to do the right thing, but engaging with them at the right time, starting to build some analytics around what's the right time of day to reach certain patients, how many times do I need to contact them before they're going to be responsive, but really staying with that individual until they're compliant. And incorporating learning and best practices into the flows, into the workflows that we're using to engage with those people. This one's this last piece is an interesting one. Another organization, so this isn't Reliance, but a group called Complex Care Solutions. They're an MCO, national MCO. They're based out of New York. But they have really taken this assessment concept to a new level. They've invested almost a year of time building this very complex annual health assessment that they're having these care managers out there engaging patients today. It used to be a 56-page paper form that would take an hour and a half. Now they've got that down to as few as 5 screens that they're using for that conversation based on the answers they're getting. And they just conducted a study, and they have, within their own organization, had a 600% improvement in diagnoses and 200% better diagnoses accuracy than primary care physicians using a technology. So there's an opportunity for us to get better and start to use technology to enhance the people that we've been put in place. So what's next for Reliance? Starting to think about being out there, being in the community, being with folks, being mobile, starting to loop in things like what's going on from an environmental health perspective, right? So I can do all the right things in the ED to help someone that's with an acute episode, breathing episode. But if I keep sending that individual back, where they're sitting underneath a moldy vent or a room with poor ventilation, they're going to keep coming back. So how do we start to get out there to better understand what's happening in the field with those patients so we can better care for them? Enhanced connectivity, so continue to work with the physician groups to get connected to the various health information networks or direct connectivity back to Reliance so that we can improve those outcomes as well. Better scheduling, starting to incorporate scheduling feeds as part of the HL7 messages so we don't have to manually intervene with the physicians to understand what their availability is. And, of course, incorporating smart devices, which I feel like it's its own conversation, so I'm not going to jump too much into that. And as I said, I would endeavor to get us done quickly, and I have. So I'm not sure if there's any questions that I can help with anybody on. Or?
Sir?
How did they immediately know that the patient wasn't picking up?
So as soon as the ED enters that patient into the system, it's firing off a cue that MyHIN is picking up or SIMHI is picking up, and we're listening real time to that same database of information. So as soon as it's picked up inside of MyHIN, it's picked up inside of Synapse within Reliance, and there's a notification rule that pings the care coordinator on their phone, at their desk, wherever they are. It says, this patient has just been admitted. Registered.
Agreement between Reliance and the facility?
So you'll probably get me out of my depth here on exactly how they've got that scheduled, but I know that there was work that had to be done with those participating facilities and Reliance, given the unique nature of their model.
And no chip in the patient. You don't put
Not
chips
yet.
in the patient. Any other questions? Well, for the last talk of the day, thank you very much.
Thanks.